Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. Today's episode discusses treatment recommendations for people with severe COVID-19. I'm joined by three expert faculty, Dr. Stephen Cantrill, a recently retired emergency medicine physician and medical director at Denver Health Medical Center, Dr. Gandhi, an infectious disease physician at Massachusetts General Hospital, and Dr. Payal Patel, System-wide Director of Antimicrobial Stewardship at Intermountain Health. This episode is part of a larger educational program titled COVID Rounds, Clinical Case Discussions on Best Practices for Inpatient COVID-19 Management. For more information on our faculty, along with the link to the larger educational program, please visit the link in the show notes for this episode. Now here's Dr. Cantrill to start us off.
So let's start. Most patients, especially those that are severely or critically ill, will come through the emergency department in your hospital. So I'm going to review what we do in the ED to evaluate and care for those patients. So first, we would talk with the patient and get their story. Now, this is a 45-year-old woman who has a remote diagnosis of mediastinal lymphoma, who received rituximab-containing chemotherapy in the past, presents to your ED with fever, myalgias, cough, and other URI symptoms with of 2 days duration. Her vitals, as shown, blood pressure 90/56, heart rate 120, respiratory rate 22. Her temp is 39.2 orally, and her O2 saturation is 90% on 6 liters via nasal cannula. Her physical exam is remarkable for bilateral freckles in the lung exam. Her medications include EPOC, rituximab. Her last cycle was 1 year ago. Her vaccination status, she did receive 2 doses of the mRNA COVID-19 vaccine 3 years ago, no booster doses. She reportedly had COVID-19 approximately 2 years ago. She did do a home COVID-19 antigen test, which was positive. First, our goal is to stabilize the patient and then assess the severity of the disease and also the likelihood of this process worsening. We will complete the workup, begin treatment if indicated, and then determine the proper disposition, either home with follow-up, ward admission, or intensive care unit admission. This lady has relative hypoxia, and you may want to consider high-flow nasal cannula in this patient, or some non-invasive ventilation, either BiPAP or CPAP, or in the most dire circumstance, endotracheal intubation if necessary. She also has probable hypotension. We don't have old records yet, so we can't tell. And she has a tachycardia and a fever. So our workup, standard history and physical, assess the severity of the disease, look at risk factors for progression to severe COVID-19, although this lady, I think, as we will find out, is probably already there. In terms of lab testing, we would want to repeat the antigen test or the nucleic acid amplification test, a complete blood count, a complete metabolic panel, a liver panel, a lactate, a C-reactive protein, a ProTime, a D-dimer, and any of the labs as indicated. In terms of chest imaging, this lady would certainly require chest imaging. And given how sick she is, I would probably, if possible, opt for a chest CT. Although some places where they have the technology are using point-of-care chest ultrasound to ascertain the severity of the disease, looking for B lines or pleural changes. An EKG and any others that might be indicated would be performed as well. Just a side note about pulse oximetry. There are considerations about that. We rely on it a lot, especially in the emergency department, but it can be altered by skin pigmentation, skin thickness, skin temperature, and many of the pulse oximeters that the lay public use at home, in fact, are not FDA approved. So you do have to question their accuracy. So for this patient, we do have some results back. Her CBC and CMP are unremarkable. Her CRP is elevated at 8.5 milligrams per deciliter. The chest CT shows bilateral ground glass opacities with some consolidation in multiple pulmonary segments. So this lady obviously is quite ill. In terms of risk stratification, the NIH does have a severity classification. This lady is not, she's in severe. And in fact, I would argue that she's critical. She has impending respiratory failure, and managing that is going to be a challenge. Now, there was a tool developed early on in the pandemic. It's called the pre-score. And what it is, it's a COVID-19 clinical severity score that gives you a look ahead in terms of the likelihood of the patient becoming more severely ill. The nice thing about this score is it doesn't require any imaging or any lab data. So you can do it early on in the patient encounter to determine, especially helpful with mild and moderate cases. So this lady, you can see her total score is 17, which means that she has a 66% chance of a deterioration, although she is obviously quite sick already. So this would put her, she's in the critical category, so she is going to be admitted to the intensive care unit. Now, things to think about. One of the things in the ED that I am always concerned about is a patient that's this sick getting the treatment started early on, not wait until they get upstairs. But if I can get things going quickly, working with my consultants so we're all on the same page in terms of what drug regimen we're going to start, I think that's very important.
I would agree, but I think the earlier you start treatment after symptom onset, the more likely it's going to be effective. That's certainly true for antivirals, and not just in COVID, but in many conditions. Let's use influenza as an example. The sooner you start treatment, the better. So I know in my emergency departments, sadly, some patients sometimes wait for more than 24 hours before they get upstairs. Not this kind of patient, because she's very, very ill.
Sick, yeah.
Hospitalization, but no need to delay institution of antiviral and, in this case, immunomodulatory therapy, given that she has indications for both.
Yeah, I think it maybe highlights, having easily accessible, whether you're using internal stewardship guidelines or whatever document the hospital is using. There have been so many reiterations of, what is the treatment for COVID-19? And, we're in a new era now where the last document may have been updated months ago, maybe even a year ago, and it maybe a new provider may not know where that is. So I think this is, really highlights how important it is both for the ED, potentially for urgent care, and for the stewardship team to have that readily available.
Couldn't agree more. There was a time when we were doing this every single day. Now that's perhaps not every single day. And so make sure that we're not using an out-of-date guidance that might be from 2022 or 2021. Yeah. This was a case where things were really changing at some point, really by the week. And so having those up-to-date guidelines is really critical. The NIH, of course, had guidelines for several years. Those have been sunsetted. So where I think I go right now is either my institutional guidelines or the IDSA guidelines. Those are kept up to date. Steve, you mentioned one thing about your consultants. I think maybe I can just put in a plug for a multidisciplinary approach here. This is where essentially you're going to have pulmonologists working hand in hand with the ED and working hand in hand with infectious diseases. And so it really is not just one. This is the nature of COVID, especially severe COVID, is a multidisciplinary consideration because in terms of how to support the person with oxygen when they need non-invasive ventilation. Clearly, our pulmonologists are the right people to work with the ED on that. And then infectious disease really has its role around antivirals and really its comments about immunomodulatory therapy. This patient may even have a role for her oncologist and others who will know about the nature of her immune compromise.
Right. And I think it's good care to try to get everybody on board as quickly as possible.
Learned this early on, but this patient did get immunized perhaps in 2021, 3 years ago or so, didn't get boosters after that, and then had COVID 2 years prior. She will have some amount of hybrid immunity, but we've also learned that some of that will wane and may wane more rapidly, than someone who's gotten a drug like rituximab, which will affect the ability of the B cells to make antibodies. So I would say pretty much everyone at this point has either been vaccinated, had COVID, or most likely had both. But there is some importance to the timing of those because at least with vaccines, the biggest boost you get in antibodies is in that first few months. T cells probably do stay around, but that's where for chemotherapy, perhaps she had steroids as part of EPOC. In fact, I think that the P in EPOC is prednisone, and so she probably has had a hit to her T cells as well.
Let's move on now to COVID-19 treatment recommendations. Dr. Patel?
Yeah, thank you so much. So we'll start with thinking about the continuum that patients can present and continue on as they have COVID infection. And I think that's really important in thinking about how the different treatments that we have available work early on in illness when you're potentially having asymptomatic infection or mild illness. That's when viral replication is often at its highest and where a drug like remdesivir would potentially be most effective. As a patient continues to potentially get sicker and become moderately ill or severely ill or critically ill in the ICU, needing potentially mechanical ventilation or ECMO, at that point, the way that COVID works is it really hits off this inflammatory cascade and hypercoagulability. And at that point, the evidence or the need for treatment is really to focus on that inflammation cascade and try to prevent thrombotic events as well. So that's, I think, a really good way to start thinking about the current treatment recommendations. So here's the IDSA COVID-19 guidelines. They have bucketed patients into mild to moderate for severity of illness, severe, and critical. And going on into severe and critically ill. So once the patient is requiring supplemental O2 or they're satting below 94%, that's when steroids, dexamethasone comes into play, remdesivir, and then depending on whether they're presenting with elevated markers of inflammation, thinking about baricitinib or tocilizumab. And then in the critical ill, these are patients who are going to be in the ICU. They're often mechanically ventilated or on ECMO and have evidence of end organ dysfunction. In the IDSA guidelines, remdesivir is not present in this group. Steroids are still recommended. And if there's evidence of elevated markers of systemic inflammation, baricitinib or tocilizumab. The NIH guidelines have a difference. They're thinking about the buckets that they have presented for severity of illness, going from the top to the bottom. There's the ambulatory setting, so someone who's not hospitalized or someone who's hospitalized for something else. Maybe someone comes in potentially with an orthopedic injury and happens to have COVID. That person should probably be treated as if they are outpatient. Once you're hospitalized and needing O2, dexamethasone is recommended, remdesivir is recommended. And if the patient is having rapidly increasing O2 needs or evidence of systemic inflammation, that's when one can start thinking about immunomodulators such as baricitinib or tocilizumab. And then as the patient gets sicker or is sicker on high flow O2, again, similar recommendations once they're on mechanical ventilation or ECMO. In this group of recommendations, it says to consider remdesivir. And then, of course, the anticoagulant recommendations. So thinking about anticoagulation, there was a ton of work in this area by different international groups, primarily by pulmonologists and in the ICU. Thinking about that hyperinflammatory cascade, there just is evidence that once that inflammatory cascade kicks off, there is more evidence of thrombosis. Now, just taking a step back from this, I think it's really important to think about bleeding risk when you're thinking about these patients. And so that is, you're between a rock and a hard place, thinking about these, starting from the beginning, thinking about someone who is in the outpatient setting or hospitalized for a non-COVID-19 reason, they would be coagulated just like anybody else on the med-surg wards. And so that would just be potentially a prophylactic heparin dose unless contraindicated. It gets more intense and really, need to be thinking about what kind of anticoagulation you're using and that patient population. There's a separate group of guidelines for pregnant patients if you do have a pregnant patient. And so if the patient is hospitalized needing O2, hospitalized on high flow O2, and then if hospitalized and in the ICU on mechanical ventilation or ECMO, these are really the recommendations from the NIH COVID guidelines. And you'd be thinking about a therapeutic dose of heparin in many of these patients, considering the bleeding risk on an individual case-by-case basis.
So our patient, again, is a 45-year-old woman, had mediastinal lymphoma, as we heard about, has gotten rituximab about a year ago, along with chemotherapy. She's presenting with severe disease, getting ill quickly, and had prior immunity, but several years ago in the form of vaccination, 3 years ago, and COVID-19 2 years ago. So current guidelines would recommend remdesivir and dexamethasone in hospitalized persons like this, and then either baricitinib or tocilizumab.
Thank you to our faculty, and many thanks to you, our listeners, for joining in. As a reminder, to view the full program, COVID rounds, clinical case discussions on best practices for inpatient COVID-19 management, please click on the link in the show notes. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Thank you and have a great day.